We all know that habits are difficult to break, especially for your littlest patients. Rather than the frustration and trauma of extreme habit-breaking methods, prefabricated oral screens are proven effective, less costly, and far less stressful for your patient and their parents. Oral habits such as thumb or finger sucking, lip biting, tongue thrusting, mouth breathing, or pacifier use are all potential risk factors for the development of significant malocclusion and jaw discrepancies. Pacifiers and thumb and lip sucking deform the upper dentition and lead to an anterior open bite, extensive overbite, and retrusion of the lower jaw. Tongue thrust, infantile swallowing, and mouth breathing cause anterior open bite and posterior cross bite. An oral screen aids the natural correction of existing anomalies, helps correct or eliminate speech defects, corrects malfunctions of the tongue, eliminates harmful oral respiration, restores normal lip closure, strengthens lip musculature, supports myofunctional therapy, and prevents prolonged orthodontic treatment and stops harmful habits. Intervening early before the deciduous teeth begin to transition to the mixed dentition can help eliminate the habit before permanent damage occurs. Providing your patients and their parents with this solution will potentially save thousands of dollars in reduced orthodontic treatment. But in addition to the dental implications of bad oral habits, there are other considerations parents should be made aware of. Increased chance of illness. Sickness from the spread of germs is more likely when children are putting dirty fingers or thumbs in their mouth. Speech development delays. A pacifier or thumb in a child's mouth prevents them from speaking and interacting with peers and adults. Social development or bullying. If thumb sucking or pacifier use is not corrected early, a child can suffer from teasing or bullying, interrupting social growth and affecting their self-esteem. Great Lakes oral screens are available in 3 versions: standard, wire guard, and bite cap, and 2 sizes. The standard oral screen is used to correct sucking habits with a neutral bite position, to prevent breathing through the mouth, and for myofunctional treatment. The oral screen with a wire guard is used for anterior open bite and to correct tongue dysfunctions. The oral screen with a bite cap is used to correct sucking habits with a displaced or retruded lower jaw and when the patient is experiencing pain while biting during the acquisition of the lower anteriors. The standard oral screen is ideal to reverse infantile swallowing, tongue thrust, lip biting, or sucking. It can be used to transition from mouth to nose breathing. The screen rests between the lips and teeth. The oral screen with the wire guard prevents the tongue from resting between the teeth. The tongue guard helps close an open bite. The oral screen with bite cap is used in cases where the lower jaw is retruded and the upper teeth are protruded. The lower jaw is guided into a neutral jaw position. The cap helps eliminate the sucking habit and trains lip closure. While every patient should be evaluated individually and instructions tailored to meet the needs of each patient, let's review some general guidelines for use. For a tongue thrusting, thumb sucking, or pacifier using patient, the oral screen should be worn every night during sleep and for approximately 1 hour during the day. For a mouth breathing patient, in addition to nighttime use, 30 minutes of daily exercises to improve lip competency is recommended. This will help transition the patient from mouth to nose breathing. The patient is instructed to pull on the holding ring and close the lips against the pull while retaining the appliance in the mouth. However, it is important to evaluate the patient's ability to breathe through their nose prior to oral screen treatment. The duration of treatment should be determined based on the patient's individual case. The appliance should be initially worn anywhere from 6 weeks to 3 months with regular follow-up assessments. Maintenance can be determined after initial results are achieved. In some cases, another 4 to 6 weeks may be indicated, or up to 2 to 3 months may be required to avoid relapse. Longer use may be indicated for tongue thrust patients. Prefabricated oral screens have been used effectively in Europe for over 40 years. Professor Dr. Rolf HINZ and Dr. Elizabeth HINZ have pioneered the use of oral screens in their orthodontic practice in Herne, Germany. They have helped thousands of young patients break harmful habits and prevent further tooth and jaw development damage. They are shown here with their daughters, also orthodontists, in the family practice. Positive results, of course, are dependent upon compliance. In Dr. HINZ's experience, children will comply if parents or caregivers are committed to treatment. For more information or to purchase Great Lakes Oral Screens, contact us today. Thanks for watching this presentation.